to get lower and to be stiffer. And so I'm telling them like, hey, if I want you to actually like land from this box and I want you to actually stop like on the dime. So you have to hit the ground at the same time that I'm like making a sound or something. So I'm going to clap and you have to be, all your motion has to be done because they're more audible. Or like even if you want compliance again, so we're going back to being softer, can I have you jump like you have like something they have to sit under? So I want you to jump from this box, not necessarily like right under, but like I need you to get lower than my hand. So I want you to jump off that box, get lower than my hand. So maybe they're not going to get there right away, but if he sees that, oh, I'm higher than that, I'm going to have to sink into it. You could even move your hand and be tricky, but like helping them figure out how to be compliant that way. So it might be some of that kind of stuff, like figuring out different cues that maybe he understands a little bit better. But yeah, play around with that kind of fun stuff. If it's just a capacity thing though, it might be just finding stuff that's a little bit easier for him to figure out, like snap downs where he's having to go deeper down. It might be ball slams where he has to like sink into the bottom. So he might not be quite ready if he just cannot get it. Maybe he's just not quite there yet. Like he can't understand how to control that velocity through a range of motion, if that makes sense. Cool.
Real quick, I feel like you gave me an idea just kind of with like you saying the ball behind too. I feel like that's definitely a really good idea to make sure that he is getting like the bend in his knee if he is super stiff. I think another thing that I've worked with, not necessarily like drop jumps or anything like that, but using like a foam roller or something in front of him too, and then having that as his target for his knees to actually come forward and hit, especially if you're trying to like load up the quad. So like the ball is great too, but at least this way you can make sure that his weight is coming forward too, and like he's slamming on the brakes from there as opposed to shifting his weight all the way back. So that's just something that, again, not with a drop jump, but it's just something I've had success with, just trying to have somebody actually like bring their knee forward and like tap the foam roller, or like even like a soft wall or something like that could work too.
100%. Yeah, we use the foam rollers too for like step offs. So I want you to step off and land, but your knee has to have that like positive tibial angle. I need you to see that you can move towards that foam roll. We've done yoga blocks on the wall too. If he's not getting it with a drop jump or coming off something, stick your knee on the wall with the yoga block. You're in that positive tibial, angle, and then can you sink down, like kind of turning it more into a drill. The other thing I would talk about, like, I think some of it, again, different depending on who you've learned from, it's called different things, but I would call it like neuromotor priming. So let's say that compliance is very difficult for him. Can you do the drill that Jim was just talking about, where you're actually like driving towards the foam roll? I have to knock it down each time. Maybe you're doing that just in a squat, then you do it in a snap down, and then you do it in a depth drop. So it's a very familiar procedure as far as like neuromotor. I'm asking you for compliance, and I do it the easiest state. So just like in a squat of some version, then I do it with a little bit of velocity, and then I do it from the height. So you could kind of even do things almost like either supersetted together or just like one right after another, so that they're getting the concept in different contexts, and yet now we're finally getting our goal from the depth drop because we've done this neuromotor priming first. Cool. Yeah, so I like that idea, Jim. That's great. Awesome. Anybody else? Anything else? We're good? Okay, cool. All right, so we'll do a little case study together. I'd be really curious to see, I know it's been a long day and everybody's treating or whatever, but it's still fun to kind of talk through some of these so that then we can see like, hey, where's the barrier, or what kind of things will we throw in there, not throw in there? And I'm just kind of curious from you guys, like Jim just gave a good example of like a way to train to get that better tibial angle. So curious kind of what we can kind of learn from each other. So, so your situation, and I'll kind of give you a little like rundown here. If you're a note taker, you can take notes so that you kind of know what's going on with the person. And then literally we're just gonna like walk through the phases of rehab to see if there's any, again, training wise, what would work, what wouldn't work. We can talk it through. Okay, so who you're treating? You're treating a 40-year-old female. She's a tennis player. She's had insidious onset of lateral and anterior hip pain on the right side. It's been worsening over the last like 3 weeks or so. Really bothers her with change of direction. And then it aches for her after tennis. So maybe for about 3 hours or so, and then it starts calming down. It's stiff in the morning, pinches with a squat, sometimes hurts to lay on that right side at night for long periods of time. And it's kind of stiff when she's been sitting for a while and goes to get up. Does that sound familiar to anyone? Tried to make it patience. You might see a lot. All right. So first thing I'd be curious, what kind of red flags would you guys be asking about or thinking about in your head? So it's right anterior lateral hip pain, 40-year-old female tennis player. Any kind of red flags come up, and you can just like either hands up or unmute or whatever to contribute. Any particular ones pop to mind? Not so much. So in my mind, oh, go ahead, Kayla. I saw you unmute for a second.
I was just gonna say, for like lower body stuff, I always ask like the red flag questions. Like, have you had any recent bowel or bladder changes? Like, do you feel like numbness, tingling, like your leg's gonna give out on you, like due to like weakness? With female, you might want to ask something about like menstrual cycle. Like, I don't know how deep you want to get into it right off the bat, but that could be a contributing factor. Or like, have you had a child? That could also be a lingering factor. That's our theme of the month at R2P is pregnancy and postpartum. So
it's on
those kinds of things. Yeah.
What is red flag about the menstrual stuff? 40-year-old tennis player. What's red flaggy about that?
Maybe if there were like changes, or you wouldn't expect 40-year-old to be like what's it called?
Menopausal. Yeah.
Menopausal. But I guess if there were like abnormalities in that cycle, it would just be something to keep in mind.
Yeah. So especially if there's menstrual issues, if there's eating issues, if there's been fracture history, anything like that, then yeah, you're looking at if there could possibly be a stress fracture. So that anterior lateral hip is very much a referral pattern for femoral neck fractures. So that's like one of your big red flags that you're like, ooh, front of the thing, she's a front lateral hip, she's a female. Yeah, ask about some of that stuff because it might help you to kind of clear out some of the red flags. And then definitely go to low back. So I was kind of going there too. What kind of questions might you want to ask for, like, yeah, like you said, bowel bladder, radiculopathies. Another thing, so again, keep in mind, she's a female. This is important. So sometimes like ovarian referral can happen there as well. So asking like just last time she's been to see her OBGYN or gynecologist to make sure that there's nothing going on there. It could be absolutely nothing, but it is almost something that you have to ask about in order to like kind of narrow down, make sure it's not organ referral patterns. What else is lower right quarter as far as if you're talking quadrant stuff? Anybody red flag for like abdominal stuff that's in that same kind of anterior?
Appendix.
Yeah, appendicitis. Yep, exactly. So if I'm looking lower right, just have it in the back of your mind. It might never happen in your whole career. Have it in the back of your mind. Yeah. So then you're asking stuff about like malaise and fever. Do you feel off in any way, shape, or form? So it just adds to your questions, which would be good. Cool. All right. And then the other thing I just wrote down is just like digestive issues. Has she been having anything like that? Because that can kind of be that lower like intestinal stuff too. And then just talking about if you think of the most common hip injury for 40-year-old females, do you guys have any idea like what one of the most common things is? Or like what you've seen like over and over and over, anterior hip? Usually it's like you're at least wondering about a labral tear. Like that's where maybe we'll go with some of our special tests and stuff. So sometimes you're looking at that bite and score too to make sure that there's not like a hypermobility going on. So to just kind of, again, not necessarily red flag, but yellow is like leading you to your red flag questioning is what you might want to look into. Okay, cool. All right, I'll give you some of her medical history. She's had a couple of ankle sprains on the same side, on that right side. She gets left knee pain on occasion. She's had 2 kiddos, to answer you, Kayla. 2 kiddos, 1 C-section. She works out on the Peloton mostly, doing like videos and stuff like that. She does this 2 to 3 times a week. And then she plays tennis about 3 times a week. She has a history of low back pain on the right, and she kind of points to that like right PSIS area, which a lot of these people will point to. So you don't necessarily have a diagnosis right away, but kind of be thinking what you got in your mind. All right. As far as like the actual screen goes, eval, I'll talk through it quickly, but kind of try to take note of what might be more like mobility oriented versus stability oriented, kind of like what we've broken down in the past for some of that diagnostic stuff. So just doing like a little bit of a screen. If you ask her to touch her toes, she can reach her hands like flat to the floor. When she leans back into multi-segmental extension, she's got like 50% or so, but if she puts her hands on her hips instead of overhead, she can get about a little, maybe like 30% further. So she does better with her hands on her hips. Rotation wise, she's got about 70% of her motion to the right, 90% to the left. So she's a little bit limited on that right side. If you ask her to do a squat, she's got a pinch in the front of the right hip, and she's got kind of like a forward trunk lean whenever she's leaning forward. Single leg stance with her eyes open, she's okay. Maybe like a little bit of lateral weight bearing in her ankles, but then eyes closed, she's like significant lateral weight bearing on that right side especially, and then like a little loss of balance, so she has to kind of catch herself on that right side. Dynamic single leg stability, so she's doing RDLs for you basically. Moderately limited on the right, very hard for her to coordinate, just a mild deficit on the left. Hip rotation wise, she has 20 degrees to the right for internal rotation, but 22 with passive. Left, she has 35, which is normal. So right internal rotation limited. External rotation, she gets 28 on the right and a cramp in her TFL, which all these ladies will say. But she can get to 33 passively. So there's a little bit of an active insufficiency there. Left is 32, still within normal limits. Thoracic rotation, when you sit her down, so we're getting rid of body parts, sit her down, thoracic rotation, only 50% to that right side. So she's still missing a lot of that thoracic rotation to the right. Left, 90%, not too worrisome. Prone hip, IR, she's good on both sides. External rotation, she's limited on both sides. Prone press-ups, 4 fingers off the table. So she's struggling with prone press-up. Slump is negative, don't have to worry about that. Active straight leg raise, she's limited. So she's got maybe like 65 degrees or so on that right side, left is normal. She's got that cramp in her TFL again, and quads are kind of crampy too. If you do passively, she's got 68, but still not that 80. So there is a mobility restriction in that posterior chain. We've got an assisted, so we've got Faber. She's 3.5 fists from the table, so normal's about 2. So she's got something going on there with hip external rotation. Fader is mildly pinchy, but nothing like crazy. Assisted Faber and assisted straight leg raise don't really change anything. So that's where you just like, I don't know if you guys, do you guys use assisted tests? Like assisted Faber SLR? So we can talk through that at some point. So that's just kind of like activating core to help out. All right. Knee to chest on the right, it's pinchy. Thomas test, a little bit of TFL and lateral 2 joint stuff going on in that right leg.